It's lovely seeing everyone. I'm spiking a fever right now, so I won't wear my nice coat. This is even better because there isn't a guy on meth who needs to be intubated. All right. So I tried to gear this a little bit toward you guys. You've seen a lot of intubations. You know a lot about airway management. So hopefully there will be some new stuff in here. I love this picture. Anyway. All right. Because he's I don't know if you can see the skateboard, but he's about to come into the trauma bay. Let's see. Yeah, somehow it's not working. Oh, okay. All right. So it turns out some kids can actually be really difficult to intubate. So you see, I guess I should stay here. Is this a mic? So if a child comes in who looks funny to you, and the anesthesiologist comes in and says, oh, I'll just intubate him, or the ER doc comes in and says, I'll just intubate him, hopefully I'll teach you enough here to have an idea when you should tell him to back off a little bit and think about some other plans. You can see here, this is not going to be pretty. But in the lower right, I don't have a pointer, do I? So proper planning and equipment really is important. I mean, there are times when you need to just back off and not intubate a kid. Oh, no, it's okay. So when do you have to intubate? I mean, one of the things is to decide if you even have to intubate, right? If you have an adult or a child who's going to be difficult to intubate and you're just intubating for a CT scan because they're not going to cooperate, if they don't look like it's going to be an easy airway, you need to rethink whether you're going to do it at all. But there are a lot of reasons to go ahead and intubate. And I'll just go through these quickly because these are fairly obvious. It's just things you'd see. So they have airway obstruction, agonal respiratory pattern, severe respiratory distress, hypoxemia, hypercarbia, they can't breathe enough. In flail chest, things like that are pretty common to end up intubating for eventually. Penetrating neck injury with an expanding hematoma, it's really nice to get a tube in those guys early. And then, of course, a GCS less than 8. Unstable hemodynamics, too, because eventually they're going to pass out when their systolic pressure is 20. Urgent airway, if it's just impending respiratory failure, if it's maxillofacial injuries that are going to need to be fixed soon, or need for CT or something. I mean, that's a relative indication to intubate. So part of what I'm going to talk about is what we think about. So, when anesthesia comes in and decides to do something with the patient, I'll try to give you a little bit of insight into what we're thinking, or what we should be thinking if it's 3 in the morning and we're tired and make a bad decision. Because you can save us from ourselves on occasion, or a lot, as it were. So awake techniques are possible, and it's not a big deal to do. We do awake intubations all the time. So if you have a difficult airway, it's much nicer to keep them breathing on their own, numb them up, do a bronch, and intubate them that way. You can even do laryngoscopies in people who are awake sometimes. Pre-oxygenating, it's difficult in kids, and it's difficult in the guys on meth who aren't cooperating, and that's why they're getting intubated. So sometimes we get really crappy pre-oxygenation. I'm sure you've seen that a lot. So it changes. Here I titled it the rapid sequence intubation because the traumas all tend to be full stomachs, or we should think about them that way. So you don't always get the pre-oxygenation you usually want. Cricoid pressure, in kids especially, can distort the airway. So when you apply it, make sure that they realize that you're pushing on the neck, whoever's doing the mask ventilation or intubating. And if they're having trouble ventilating, or if they're having trouble intubating, you probably need to relax your cricoid pressure, right? Because you can completely close a child's airway and even an adult's airway if you push hard enough, just by pushing. The IV induction that we do in people who are full stomachs, we want to paralyze them fast, right? We tend to use rocuronium or sucks. There's nothing magic about the rocuronium. It's just to really get a fast intubation with something like vecuronium, you have to use 4 times as much, and they're intubated for like an hour or 2 hours. They're paralyzed. But at these doses of sucks and rock, you're ready to be intubated in 30 seconds to a minute. And that's important because if you go early and they're not fully paralyzed and they gag or they retch a little bit, whatever's in their stomach just comes right up at you. And then, of course, we're giving some hypnotic anesthetic, which isn't really within the scope of the lecture. Infants and toddlers, though, I give them all atropine. If you're going to give sucks, you should give them all atropine anyway because they can get very bradycardic. But if they get hypoxic, if you have any difficulty with the airway, kids, they so quickly will become bradycardic that you're doing chest compressions just because they got a little hypoxic. And if you give them the atropine, you have a lot more time of hypoxia before it gets interesting. So classically, when we do the rapid sequence, we don't do mask ventilations, right? You've probably all seen that. We just kind of sit there and do nothing. It looks a little silly. If I haven't pre-oxygenated well, if it's somebody who's obese, somebody who has not very good functional residual capacity, if it's a child who couldn't pre-oxygenate well, or a child who doesn't have a lot of reserve anyway. I'll mask ventilate them really gently. People have looked, people actually, it's almost hard to believe, but it was a decent study, did good cricoid pressure on kids and breathed for them and saw if they insufflated any air in the stomach, and they went up to 40 millimeters of pressure ventilating with a mask and didn't insufflate the stomach in kids getting good cricoid. So if you're giving good cricoid and you use really gentle pressures, like 10 or 15, just barely moving the chest, but enough to get some oxygen in and see a little CO2, then they don't desaturate, and you don't have this big kind of drama when you're trying to intubate them where your first view isn't perfect and the sats are going down and you're jamming a tube in. And so people have studied this as well, kind of injuries around rapid sequence intubations, in particular in kids, because they desaturate so fast. And you do have more trauma when you have no mask ventilation and a quick desaturation, because everybody's in a hurry. And everybody's nervous in the room too, and it's just not pretty. So I frequently will mask ventilate a bit. If the resident doesn't mask ventilate afterward, I'll tell them, it would have been probably a lot nicer for you if I'd have let you do that. So I think I covered all this. Now, as soon as paralysis is achieved with these full stomachs, we're trying to get the tube in. That's the whole purpose. You're minimizing the time that they could possibly aspirate, so you get the tube in as quickly as possible. If I'm looking and you're giving cricoid pressure pretty heavy, or even giving it properly, I might have two problems. One is I might not see the airway because it can be pushed, the airway might be pushed a little off to the side, or you might be a little high and actually closing tissue over the top of the airway. So not only can that make mask ventilation impossible, but then I look in and I don't see anything I expect to see. So what I might have you do, or what you should even offer to do, is back off a little on the cricoid. So you see one of us struggling with a view, ask them if they want you to back off on the cricoid a little. And also when I try to put the tube in, maybe I can't pass it, and again you can back off on the cricoid pressure and the tube often will go. So again, these are things kind of trying to, hopefully you guys can save us from ourselves. Paralytic drugs, it's worth talking about just because it's what takes your airway away. When you make that decision to intubate somebody for a CT who's got a perfectly good airway, once you push your paralytic, you're in a place where you're going to have to ventilate them somehow. So with succinylcholine, we already talked about it being a rapid onset. Contraindications are important to know. Burns or crush injury, they can have problems with hyperkalemia. Open globe injury, clearly with an open globe, if I give you sucks, I can squirt out all the vitreous out of your eye because you get the spasms you guys have seen, and then instead of it becoming a repair, it becomes an enucleation and they lost their eye. So, so it's a big deal. Don't use sucks with anything that might be an open eye injury. If there's a history of malignant hyperthermia or pseudocholinesterase deficiency, which just means they don't metabolize the sucks, so they stay paralyzed for a long time, it's more inconvenient than dangerous. Any neuromuscular disease. So if you have denervated muscle from a stroke, if you have muscular dystrophy, if I give you sucks, I will very likely kill you. I might get you back. Maybe I'll get your potassium down from 12 eventually, but it can be an ugly arrest. There's plenty of case reports of people dying after succinylcholine. So it's a good drug. You just need to know when not to use it and when it really has a benefit.
Are you saying anyone that's had a stroke?
Yeah. If they have any residual muscle weakness, I never use sucks, because if they've got denervated muscle, one of the things we think happens is they get a bunch of extrajunctional acetylcholine receptors. So when you give them the sucks, if I give any of you sucks right now, your potassium goes up maybe by 0.5. But if I give it to you and you've got a bunch of muscle with these extra receptors that are kind of unregulated, not normal, your potassium might go up by 2 or 3 or 4. So it's variable, but it's really not worth the risk. Likewise, if you get regular dialysis and you haven't been dialyzed for a few days, I usually don't use sucks because your K goes up and you can't deal with it.
No. So this is not a new stroke, it's a muscle weakness.
If it's a brand new stroke, yeah, if it's a brand new stroke, you're cool. If it's a brand new burn, first 24, 48 hours, you're good. I usually make it 24 hours, so fresh burn, sucks is fine. But if they have an old injury, it's a relative contraindication if they're just laying around in the ICU for days and days, because the same kind of thing happens with that muscle that's not being used. But that's more of a relative contraindication. I tend to be very careful with sucks because I think the benefits of sucks are few. And I'll talk about theoretically why people still use it and what the benefits might be.
And if you don't use it, then you use back.
No, rock. If it's because I'm talking about rapid sequence stuff in the trauma bay. But so sucks is the only thing that does that. It's a depolarizer. People talk about being a depolarizer, so it's depolarizing the membrane. That's why you can potentially have that problem. So rocuronium and vecuronium we talked about a little. The doses of rock we're using are just really high. You can do the same thing with VEC, but then they're even really, really high, much more than the usual dose people use. So the risk you take with VEC if you use the smaller dose is that you go into intubate and they close their cords, or they push against your blade and you can't intubate them properly, or they retch and they vomit. All right, this is a really old picture actually. He's in kindergarten now. But so I'm going to try to hopefully keep it semi-interesting by talking about some unique problems you can see with kids and that you could see in the trauma bay. So endotracheal tube sizes, you can use the Broslow tape. One thing that won't help for is neonates. So for neonates, if you use the rule of 1, 2, 3, 4, 7, 8, 9, 10, you can say if you have a 1, 2, 3, or 4 kilo child, then at the alveolar ridge where the teeth would be, you could put the tube at 7, 8, or 9, or 10 centimeters. And you'll occasionally have somebody come in who's been in a trauma and they've delivered their baby, or the baby comes to you, you're working, moonlighting in an ED or something. And it's good to know if somebody puts the tube in at 14 centimeters, clearly that is too deep. And actually, I know of a child who arrested and they ended up withdrawing care because the child was hypoxic for so long that they had global ischemic encephalopathy. But the only problem with the resuscitation was they put the tube in at 14 centimeters. So this was a newborn who had an endotracheal tube that was too deep, was probably just ventilating one lobe. None of the other lobes were open. So it was a huge shunt, way desaturated, bradycardic, cardiac arrest, just because the tube was deep. So actually having an idea of those sizes is useful, especially because Broslow doesn't help. For older children, you can use 16 plus age divided by 4 for the internal diameter of the tube that you choose. Depth is good to know. For bigger kids too, you may have gotten the Broslow out and you put the right tube in. If you take 10 plus roughly the kid's age, the child's age, you'll come up with about how many centimeters it should be at the teeth or the lip or whatever. So that's useful too. If you have a 10-year-old kid and you see it's in at 26 centimeters, you're pretty likely to be deep. So you can see teeny tiny airway, and this child actually is breathing through that. So some kids will have very small glottic openings. If they have a foreign body, the foreign body might be obstructing most of the trachea. So in cases where you have really small airways, think a lot about heliox. I mean, heliox in I think probably is used more in kids than adults because their airways are so small to start out with. You just take away a little bit, they can be well and truly in trouble. Other things you can have, this is a dynamic process where a child with laryngomalacia just doesn't have very good structure around the opening of their airway. So when they take a breath in, there's this Venturi effect. So the pressure increases and actually pulls in all of these structures to close the airway. So a child like that gets really upset and they can't breathe. Every time they try to take a breath in, their airway closes. And this can be especially bad, and it can even be difficult sometimes to mask ventilate them because every time you do the positive pressure, it does the same kind of thing with pushing it in. This is just an interesting picture. This is a newborn with a laryngeal web across their trachea. So as soon as they're born, they can't breathe. They've got no airway at all. And sometimes you can push a tube through that, but you can see it's fairly interesting resuscitation. Expanding neck. I'm sorry? Well, if it's a complete obstruction and you can't push through it, then the baby needs a tracheostomy. And if you don't have somebody there who can do that, they're just going to die. I'll talk to you about something else you can do in kids. I'd meant to bring there's a couple show and tell things, but I'll show you something on the screen that would be helpful to think about other ways to deal with kids who have a complete obstruction up high. So expanding neck masses. So another thing you'll see in the trauma bay are people who either have a traumatic penetrating injury or maybe they've just had surgery and come in through the trauma bay or emergency room because they're having airway problems. So you can get complete airway obstruction from these kinds of things. Operations, superior vena cava obstruction just causes a lot of swelling above because you don't have normal venous drainage. You can consider this in the differential diagnosis of any stridor, really. You wonder if they've got some kind of expanding mass that's going to make the stridor even worse. If it's a post-surgical neck bleed and they've still got their sutures in and it's a fairly fresh wound, you can actually open it up to relieve the pressure. Often it's a slow venous bleed anyway. It's not like they're going to bleed out when you open it up, but you might release enough pressure that their airway opens up a little more. And we don't always think about it. We might be in there thinking about how am I going to intubate this kid, and you might say, well, you know what, we can take the sutures out. They may need a tracheostomy below the obstruction. If you've got an obstruction that's already fairly fixed and dramatic, and maybe I won't even be able to fit a very small endotracheal tube through, they may even need a tracheostomy. or cricothyrotomy, depending on who's doing it. So here you can just see, you can collapse the airway anywhere, right? The main stems can get collapsed from bleeding or from masses. Over here you see something that's a little bit higher in the neck. But that kind of thing can be a really big deal, and it might even make it hard to pass an endotracheal tube. So diaphragmatic hernias, if you're in a car accident, you can potentially blow out a diaphragm, right? I don't know if you guys have seen that, but if you have somebody in respiratory distress, and especially if it's a kid, it's easier to see, and they have a really scaphoid abdomen, and you hear bowel sounds in the chest, there you have your diagnosis. The thing with kids is they handle that less, they don't handle that as well as an adult might. Adults on one lung ventilation can often do pretty well. All right, so with kids though, as they cry and take in a lot of air, you know, they swallow a lot of air. You've seen belly x-rays from kids who are crying and it's just, there's air everywhere. But unfortunately it starts filling up their chest, and then they've got almost a tension, they've got tension in their thorax that's keeping their heart from filling well, keeping their lungs from filling well. So with kids, there's a couple things you don't want to do. If you think this is what you're dealing with, you know, you have the respiratory distress, scaphoid abdomen, you hear bowel sounds, or you have an x-ray that looks like this, you can see the trachea shifted all the way over, so there's already shifting, there's tons of pressure on the lung and the heart, and this is filled with gut that has a bunch of air in it. So if you have something like this, you don't want to mass ventilate them for a long time, right? Because you're probably going to fill up their belly with even more air. So if they are in enough respiratory distress to need support, you're going to intubate them earlier, right? If they don't have much respiratory distress, no big deal. But if you're being forced to deal with their airway, you'll want to intubate them as soon as possible. And then use an NG tube to decompress the bowel. Either way, I would decompress their bowel. If they're not in much respiratory distress at the time you see them, but you see an x-ray like this, I would definitely get a tube down there so you can empty air out as it comes. All right, so preparing for intubation. Anesthesiologists are really paranoid beasts, and probably all of us should be. I think you guys are paranoid too, because you have the guy comes in with stable vital signs and then bleeds 3 liters into his belly and ends up coding. So could be dolphins, maybe not. So the things that we look at on an airway that actually, in kids especially, you can see most of this just looking at them cry. If they have really good mouth opening, great. That helps a lot. If they can't open their mouth, that's going to be a problem. Jaw fractures occasionally are a problem that way. Really prominent front teeth makes it hard for us to intubate. So you see somebody with big buck teeth, it might not be straightforward for me to get a good angle to see their airway. Loose teeth, good to know about just so we can get them later, like pull them out of the lungs or wherever they go. Do they have any abnormalities like of the face that has to do with the mouth or the tongue? Mainly what we're doing when we intubate, we're just putting a big tongue depressor in the mouth and getting the tongue out of the way. So if you make the mouth small, then it's harder to get the tongue out of the way. If you make the tongue big, it's harder to get the tongue out of the way. Making the mouth small, a lot of times you can see it, like your big clue is to look at the space that we push the tongue into. So that's all this stuff under here. So if you feel where the hyoid bone is, and if you feel where the tip of the chin is, and it's really small, you just get one finger between there, even in a small kid, that means I'm not going to physically be able to get the right angle to look at the airway, because everything is too compressed in there. So that can end up being a very difficult intubation. This is a little girl with Treacher-Collins syndrome, but you see her chin is small. You'll see that. You see her, or you see an adult, like she'll grow up and still look that way. Her chin doesn't have catch-up growth. So you see her laying there in a C-collar, and I'm about to put her to sleep and intubate her, you probably should stop me, because it's going to be ugly. And here's a guy with a more normal, kind of a more normal-looking chin. So again, you see facial abnormalities. Those can be a clue that it's going to be a difficult airway. Other external things, any stridor, neck masses, obesity, any other indications of some kind of airway obstruction risk, that may be an issue for me to try to mask ventilate them once I paralyze them, and also an issue for me to try to intubate them. The range of motion, you know, there's probably 2 patients a year that you see who are not in a C-collar, but if they aren't, you can have an idea if they move their neck, or if they tell you they've had a bunch of neck surgeries and actually they're stuck stiff like this. Again, it just mechanically makes it hard for me to get a view of the vocal cords. Lastly, you know, if there is anything available, scans, even that x-ray, if that x-ray came up before you intubated the patient, the one that had the trachea being compressed externally, that would be a good clue. So it is worth looking at whatever scans might be available. You don't have to memorize this, but it turns out in looking at the size of the mouth in adults and kids, what makes the most difference is if they open their mouth and you see uvula and everything really, really well, that's a really good sign. If you don't see anything recognizable except tongue and soft palate, that's a really bad sign. The ones in between, not so predictive. But if you can get someone to open their mouth, it's worth doing because it at least lets you know if you're getting into a lot of trouble. Here's a boy with Beckles-Lehman syndrome, big tongue. So if they can't, kids with Down syndrome as well will have you saying just when they're out and about in the world, their tongue is so big they can't even keep it in their mouth. That's a bad sign. It may be difficult just to get it out of the way. And then of course they grow with preacher collins and the small chin. Airway edema, the reason kids don't do so well with airway edema is any little bit of change in radius you make, you're increasing your resistance to the fourth power. So you take a 4mm infant airway and even make it a millimeter smaller, it's really hard to breathe through. So small amounts of swelling in kids are a big deal. So you can get maybe a lot of bang for your buck out of racemic epi or giving them some Decadron and waiting some time, although that takes some time. And then also Heliox can be useful while you're waiting for the ENT surgeon to come in who can do a trach. So you can sometimes buy yourself time with Heliox or racemic epi, things like that. And then when you intubate them, you're probably going to have to use a really small endotracheal tube if they're that swollen. I'm not sure why I put this picture here. I pulled this slide from an old lecture, and but it's a cute picture, I guess. So I'm going to talk about a couple things. I'll just go a few more minutes. Is the next speaker here?
No, we have a little break.
Oh. You guys can start taking a break too while I talk. So I won't tell you what I'm going to talk about. Mass ventilation, you guys know how to mass ventilate. The couple things I'll show you with kids. If it's a baby, in order not to cause mischief by pushing all this soft tissue back into the back of the throat, I'll put one finger on the chin and then just have these couple fingers on the mask, right? So that when you're ventilating a baby, only these three fingers are doing anything, and you're just on bone up here, and it keeps you from pushing the tongue into the back of the throat and obstructing them. If you've got another thing with mass ventilation, if you have somebody you can't ventilate and you feel like you have a great seal and you're not pushing their tongue back, it might just be that their nose is obstructed. And the way we mostly mass ventilate, we completely shut their mouth and shut their lips. So that's where oral airway helps a lot, partly to keep you from obstructing with the tongue at the back of the throat, but also sometimes just to open the teeth and give yourself a way to ventilate through the mouth in somebody whose nose is completely obstructed. So you'll see this in people who have a nasal fracture, that's a common one, or have had previous nasal fractures, and you guys see plenty of that. And also just a bad cold. I've had kids that were completely unable to mass ventilate until I opened their mouth. You know where airway, this is the commonplace airway obstruction happens, where it actually helps to put an airway in. So you can see that the back of the tongue obstructs and that there's an oral airway or a nasal trumpet. The trumpet's good in somebody who's awake. They tend to tolerate it if you just put a little Vaseline on it. Sorry, if you just put a little lidocaine on it. Estimating sizes of oral airways or even nasal trumpets. If you're going to put it in the mouth, just take the edge of the lip to the angle of the jaw. That'll roughly be a good size to get in the right spot. If you put it in the nose, I just measure from the edge of the nose down to the angle of the jaw. The reason you don't want it too deep is you can push the epiglottis in, or you can even obstruct the airway. You can tickle the vocal cords, and it's really uncomfortable. They have some laryngospasm, whatever. If you put it in too shallow, you can actually, or if when you put it in, you trap the tongue, you don't really get under and behind the tongue, you can push the tongue really aggressively against the back of the throat, and that's a really nicely obstructed airway. So if you get the right size, theoretically you get back behind the tongue, but you're still above the epiglottis and the glottis, and then you have a nice pathway for air to go. Positioning is important. Kids, the infants and toddlers have really huge occiput compared to everything else. They got these big old heads. So when they lay down, they're really flexed like this, and they can be very hard to intubate, hard to mass ventilate. Their airway's kind of closed. So with infants and toddlers, really all I do is put a chest roll, I put a shoulder roll under them. As kids get older and a little more normal, they might have a little pad under their head, like a little operating room for adults. And what you want to do is then get their head in this position. So it almost looks like they're sniffing a flower. So we talk about a sniff position. Basically, it's just that your head's a little forward like this. So you're a little extended here and you're a little flexed here on your chest. So if you get roughly that sniffing position and the chin is way above the sternum, that's a nice position to have somebody in to physically be able to get a view at the airway. Don't forget that some kids are big too, and you need to kind of ramp them up to get the mechanics right. So the best thing to look at here is the chin is well below the sternum here when she's just lying flat, and it's really hard to intubate somebody that way. I've had people who had cardiac arrest because of a respiratory arrest, because they couldn't be intubated in an emergency department. And I go to intubate them and just prop a little pillow under their shoulders, or have somebody physically pick the shoulders up, and then with my blade pick the head up to get this position where the chin is well above the sternum and you have a nice sniff. And it's an easy grade 1 view. A medical student could intubate them on their first try. And seriously, that's people who have had brain damage because they were hypoxic for so long. And it purely was positioning. That's it. And you know, I see kids at Children's that weigh 150 kilos sometimes. So that kind of thing can come in. I put this in so you guys wouldn't feel like I was just talking about kids, I guess. But, are you guys still cool with me doing a couple other little things? I'm going to talk about some of the things that we should think about, and hopefully you guys would think about for us when we have difficult patients in the trauma bay. Standard laryngoscopy is easy. If I'm having trouble with my view, actually my favorite first blade in somebody in C collar is this nice straight one called a Miller blade. This Macintosh is the one most people here use. It's just, I mean, that's what people intubate with. The problem is this doesn't give you a very good view because it's curved. So where the tip of the blade is, I don't really see well. So with this blade that's nice and straight, if the mechanics aren't good at the intubation because I didn't put them in a sniff position because I don't want to destroy their spinal cord, this Miller blade actually is better. So sometimes just switching blades will make a good view. You guys could even hand somebody the straight blade and say, do you want to try this one?
You're the only person who doesn't use a Mac 4.
Well, that's the other thing though. At least they're starting with a Mac 4. So I try to have the residents understand that you want your first view to be your first best view. Sometimes you go in and you realize your blade's not long enough. How stupid is that, right? I mean, you should use a really long blade so when you go in, you've got everything you need to go in and get it. Because they're desaturating at that point because most people don't mask ventilate and then they were on meth and they couldn't be pre-oxygenated. Meth is my drug of the day. So I'll make the next guy really drunk. So a long blade is good. The problem with the Mac 4 is the anterior posterior diameter or length of the blade is bigger, so it's harder to fit in the mouth if it's a little closed. And you don't get a nice straight shot to your view. So somebody who can't put in a good sniff position, like they're in C-spine precautions, the Miller blade completely makes sense. In their defense, they need to practice with it before they use it in the trauma bay because it's a little different to use and you can have issues with it. But it's worth changing. Like if a resident can't see something and I use a Miller, usually I'll see something just fine. All right. The awake intubations we do, we have to sedate them a little bit. We topicalize their airway with local, and then with a bronchoscope, we go into the airway and just put a tube off over the bronchoscope into the trachea. It's difficult in kids because you need some cooperation. You can do this in kids, but there's tricks that we have to get them compliant. It usually involves ketamine. That's my next drug of the day, I guess. Another thing we can do is if we have a view of an airway that maybe looks like this, you just see epiglottis, but I can't really see where I need to put my tube, or even just tongue, I can take this stiff tube here, and shove it into the airway blindly, and maybe have it angled a little up, and you feel yourself hitting tracheal rings. It's actually really cool. So you feel yourself hitting tracheal rings, you know you're in the trachea, and then you put an endotracheal tube over the top of it, like over the top of a straw, and you can put the endotracheal tube in. This is a video of that won't play on my PC. But it's nice to know that's an option we have, and it's really fast. You don't have to do a bronchoscope, you don't have to see it, you don't have to get a big tower with the camera.
The same as you carry those?
Yeah, we actually have one in our bag. LMAs, so theoretically an LMA is supposed to fit this way, right? It's supposed to be back behind the glottis and you breathe. Well, it turns out it's not always right there. So it's good to think, if you stick an LMA in on your own, because no doctor showed up yet, I mean, that's great. You should try it. If you can't intubate, go ahead and try to do this. But when you put it in, sometimes you have to troubleshoot them. So you can see this is a pretty good view of the airway. This is looking through the LMA with the bronchoscope. Here, the tip of the LMA is between the vocal cords, and now I'm looking in the trachea. And unless the patient's paralyzed and really deeply anesthetized, they'll be coughing and clucking. It'll be nasty. This one, you can see, these are the arytenoids, the little cartilages usually at the bottom of the airway, and they're pushed up into and obstructing the airway. Here you can see you're pushing the epiglottis and both of the arytenoids in the airway, making a little thing to breathe through. So the LMA isn't a complete no-brainer, and so if you're not breathing well with it, just take all the air out of it, reseat it, put it back in, and blow it up again, and often that's all you need to do to get it to ventilate properly. remember, we can intubate through LMAs. So if I can't intubate somebody in the trauma bay, I'll just stick an LMA in, go and get a bronchoscope, ventilate them in the meantime, and then intubate them through the bronch. And you can actually ventilate the whole time, because when your endotracheal tube that's loaded up on your bronchoscope enters the LMA, which it enters really early, you have a pretty tight seal because it's tight in the LMA. You put a bronch elbow on the top of the endotracheal tube, and you do all this ventilating the whole time. It's actually very slick. Cricothyrotomy in kids, you can actually ventilate with a bag in really little kids. Instead of, you can't do jet ventilation, you're just going to blow their lungs up and kill them, even in adults who are really obstructed. But you can put a bag on them and ventilate. All of you know about the cricothyroid membrane, you can put a needle through it. The thing you don't know is if you put like a 14 gauge angiocath in, at the end of it you can put a 3 cc syringe, and the little connector that usually goes on a 7.0 endotracheal tube will fit in the 3 cc syringe, and then you can just ventilate with a bag. So it's pretty cool. If that doesn't make sense, I can put it on paper and write it down again. I have a picture of it somewhere. Retrograde intubation, you can put a wire through it. There was a case at Navy just a few months ago. Somebody actually had a Marcaine allergy, a real Marcaine allergy that their cardiologist blew off. Said, yeah, right. Gave him Marcaine. Within 10 minutes, he could barely breathe. He was getting swollen. His airway was swollen. There was a resident walking by, and in their bag, they have a little wire, but they didn't have a whole kit. But they had a wire in their bag. He looked. He couldn't see anything. They put a needle in his neck, because then he had completely lost his airway at that point. Put a needle in his neck like you're doing a cricothyrotomy, but go up, thread a wire through it, and then when you do your laryngoscopy, you see what fold of tissue the wire's coming through. Because you look at this, you don't know where to put your tube, really. And this is actually a pretty good picture, too. So anyway, he put the tube where the wire was, and he was fortunate enough to get in. You can also use the tube to put through the suction port on a bronchoscope, and it'll drive your bronchoscope right into the airway when nothing was identifiable. This kind of thing you see with epiglottitis, you see with any trauma to the airway where you have swelling, any trauma to the chest where the superior vena cava is occluded and you have swelling in the airway. So all these things, I might do a laryngoscopy and not see a darn thing. And so a wire can be helpful, and there's techniques to deal with that. This is the last slide. The thing we need to remember is we should try to pre-oxygenate. We should be evaluating the airway at least in a cursory fashion before we intubate these people in the trauma bay. If it's an emergency, it'll be a pretty quick evaluation, though. And then you choose your drugs carefully. If you choose succinylcholine, some people choose it because they feel like it'll wear off in time. If they can't intubate the patient, they'll start breathing again. But you're throwing the dice on that one, because some people stay paralyzed for 9 minutes with it, and some people for a few. And then this just mentions there is a black box warning in pediatrics for succinylcholine, because if they have an unrecognized muscular dystrophy, even if they have no symptoms at all, you give them sucks, their potassium could be 15 on your next lab. So, and there's multiple case reports of that kind of thing. So, any questions? Isn't that cute? This actually, I should give this to the previous lecturer, because this is what it feels like, right? And any questions?